Hello and welcome to another Cincinnati Heart Failure lecture series. My name is Mahyar Poryahi, and this is a part 1 regarding decompensated systolic heart failure. We'll cover from definition to epidemiology, classification, etiology, go through history and exam, and discuss imaging. So, talking about definitions, what is heart failure? It's a complex clinical syndrome that results from any structural or functional impairment of ventricular filling or ejection of blood. The manifestations of heart failure relate to the backup of fluid due to an inadequate pump, which translates to congestion, whether pulmonary or systemic. Treatment goals focus on preventing progression of disease and reducing disease-related morbidity and mortality. Why is heart failure important? Heart failure accounts for 45% of cardiovascular death in the US. Approximately 6.7 million Americans over 20 years of age have heart failure. The lifetime risk of heart failure has increased from 1 out of 5 to nearly 1 out of 4. And these are individuals that develop heart failure in their lifetime. Why in the acute decompensated space? What is important to understand? That readmission rates are high and the post-discharge mortality is still elevated. So what about definitions? This is at this point a little bit outdated, but we came up with the universal definition and classification of heart failure. And this unified the AHA, ACC, the Heart Failure Society of America, and some of our international partners in terms of terminology and what we use for heart failure. So let's talk about it. It looks at one definition, which we covered already. The other is looking at the stages. Stage A covering at-risk population. Stage B looking at pre-heart failure or patients without current or prior signs or symptoms of heart failure, but with evidence of one of the following, such as structural heart disease, abnormal cardiac function, and or elevated BNP or other natriuretic peptides or troponins. Stage C, which is a patient with heart failure signs and symptoms and other structural or other abnormalities. And stage D falling to the advanced, which is severe symptoms and signs, recurrent hospitalizations, especially with GDMT, refractory or intolerant to GDMT, or requirement to consider advanced therapies or palliative measures. How about by ejection fraction? We finally came together and considered heart failure with reduced EF being any ejection fraction less than 40, mildly reduced between 41 to 49, preserved above 50, or heart failure with improved EF, which is baseline was less than 40 and now it's increased to above 40 or increased by 10. And so that's heart failure with improved EF. Language matters in heart failure. So we used to use the terms of recovered EF or other terminology. And what we came to discuss is that heart failure in remission or persistent heart failure matters more. It kind of parallels us to some of the cancer-based terminologies. So this kind of covers the different stages we just discussed. It also talks about some of the therapy consideration that we might consider. So I'm going to quickly go through this. We talk about stage A. Therapy is heart-healthy lifestyle, preventing vascular and coronary disease, consideration of ACE or ARBs in appropriate patients for vascular disease or diabetes, statin as appropriate to reduce overall risk. Stage B, We now again consider ACE or ARB as appropriate, beta blockers as appropriate, and in select at-risk disease types, we might consider ICDs or revascularization. For stage C, we start talking about the 4 pillars of heart failure. And in addition to that, reducing disease-related comorbidities, possibility of additional drugs, and consideration of defibrillators or CRTs, plus or minus revascularization depending on the etiology of the heart failure. Stage D gets into the more of the advanced realm, whether in regards to advanced therapies or palliative care, and so we can discuss that a little bit later. What about mortality? Is one better than the other? And I think this graph really works well to demonstrate that it doesn't matter if it's heart failure with preserved ejection fraction. Sorry, the heart HFBEF is a very old terminology, and this is old data. So this would be heart failure with mildly reduced EF, or heart failure with reduced ejection fraction. Within 5 years, they have practically a similar incidence of mortality. And you can see that by both the graph and otherwise by the outcomes below. What about precipitating heart failure factors for acute decompensated? So I'm sure you all can name a few, to say the least. Acute ischemic events, uncontrolled hypertension, tachy or bradyarrhythmias, other cardiac diseases, noncompliance, toxic substance use, and many others. This graph breaks it down to a percentage based on a study that was done on what makes up the overall percentage, and I'm just going to hit probably the top 3. So acute ischemic event, acute infection, and then arrhythmias or non-adherence making up the other 2. How about history and exam? History and exam play a big factor on figuring out, one, where heart failure is and whether there's what the etiology cause might be into this heart failure. So I'm going to quickly go over this. Family history, specifically looking for some of the family or familial related heart related problems or heart failure related problems and the age that it occurred. Trying to assess both risk for early onset coronary artery disease, arrhythmias, genetic factors that might relate to heart failure itself is really essential, but also for some of the other diseases. If autoimmune diseases run in the family, and or if the patient themselves, which is not family history but relates to the patient, if they have carpal tunnel or other related problems. Toxic substance, whether use or chemotherapy related agents that could have cardiac events, that could be helpful. Weight assessment can be helpful. Assessing physical exam for JVP is essential. Looking at peripheral edema or orthopnea is essential. And so this is the recommendations as mentioned. What about initial labs in the hospital? So looking at complete metabolic panel to look at liver function, kidney function, and electrolyte abnormalities is helpful. CBC for anemia is essential. Lipid panel can be helpful, especially for coronary artery disease or other risk assessments. UA, again, from both infectious but truly for kidney also related problems. Thyroid, as it can, both hypo and hyper can cause problems. HIV, BNP, and EKG, and additionally can consider serum protein electrophoresis, A1C, ferritin, iron, and for the follow-ups, basic metabolic panel or renal panel, depending on what is provided at your institution. What about role of BNP? So BNP can be very helpful for risk assessing a patient, but just realize in some patients it could be falsely high versus low. So quickly going over a couple: older age, female sex, acute kidney or chronic kidney issues can play a role of it being increased, and obesity, heart failure with preserved ejection fraction can decrease it. This is a quick view to assess some of the genetic assessments and some of the phenotype categories. So it looks at the category, the patient or family member related questions, and what other questions to be asked or to discuss. What about imaging? Echo can be very crucial. Cardiac MRI at least once to kind of look at other etiologies if it's not clear can be helpful. Stress imaging to assess ischemic disease will be helpful, and coronary angiography similarly for ischemic related diseases. What about invasive? In patients with heart failure, biopsy may be useful for specific diagnosis, which is suspected. In setting up patients with heart failure with persistent or worsening symptoms, signs, diagnostic parameters in whom hemodynamic are uncertain, invasive hemodynamic monitoring can be useful. Routine utilization is shown to have no benefit. Routine biopsies can cause harm. So when we continue on, we look at the diagnostic algorithm for patients with suspected heart failure. As we've already discussed, clinical history, physical examination, ECG, labs play a critical role. In patients that we further need risk stratification, we can definitely use BNP and NT-proBNP, which help further guide us. Transthoracic echo can further assist and guide us in both subclassification and appropriate medications. Once heart failure diagnosis is confirmed, determine the cause and classify further, and then evaluate for precipitating factors, initiate treatment as we've previously discussed. This is a good slide to bring everything together. This is further dividing it for the emergency department. So a patient comes in with acute heart failure. Is there high likelihood of heart failure diagnosis? Critically ill at presentation? Yes, admit to critical care. No. Prior history of heart failure? No, admit for evaluation of new heart failure. Yes. Marked degree of congestion? Yes, admit. No. Is there medical risk complexity high? If it's medium to high, admit. If it's low, need for more further information about history, regimen, or comorbidities. If yes, obtain information. If no, consider multiple things, but possibly of home with recheck, obs versus admit. That brings us to the end of lecture 1. Thank you and take care.